Hi, my name is Sue Faust. I am a pharmacist at Summit Health System, and I teach at Northeast Ohio Medical University. We're going to talk about medications in older patients today. So by the end of this presentation, I hope that you'll be able to explain why older patients are more prone to medication adverse events. Also be able to identify a method to avoid medication adverse events in older patients. And finally, identify resources to assist in optimal medication use. When we look at what is in the literature about medications in older patients, there are many facts. I think some of the most pertinent ones I have listed on this slide. First, older adults are twice as likely as others to come to the emergency department for adverse drug events. Second, studies have found that 60% of our older adults are on a medication without a current indication. So many times we are seeing some overuse of medications. And lastly, the risk of frailty increases with the number of medications. So I want to introduce you to Mr. and Mrs. Harrison. Mr. Harrison is a 92-year-old man, and he has actually been doing very well. In fact, he has been helping his 91-year-old wife since she had a stroke 8 years ago. He happens to comment to you that she's much more sensitive to medications than she used to be. She had to stop several of her medications in the last year due to side effects. So, is there a good explanation for Mrs. Harrison's increased sensitivity to medications? So the answer to that question is absolutely yes. There are physiological changes that occur in our patients as they age. As these changes occur, we do see changes that actually occur in how the body is able to handle medications. On this slide, I have listed pharmacokinetic changes that occur in older patients. When we think of pharmacokinetic changes, we think about what the body does to the medication. First of all, we have to absorb the medication to get it into the body. And we do see some changes in absorption. Our body tends to absorb medications a little bit slower, but we do not really see a change in the extent of the absorption. Next, the body needs to get that medication to its site of action. So we see changes that occur in distribution. Older patients will tend to have less body water. They will tend to have more body fat, and they tend to have lower albumin. All of these things will affect how the drug is transported throughout the body. We can see some changes that occur in metabolism of the medications. Usually this is due to drug interactions, and usually metabolism occurs in the liver. So more so for the fact that many of our older patients are taking many medications. Lastly, we do see some predictable changes in renal function as patients age, and any medication that is eliminated by the kidney will need to have lower doses in these patients. Pharmacodynamic changes refer to what the medication does to the body. In general, our receptors become more sensitive to medications as we age, so we'll see more effects from the same dose. There are a few exceptions to that rule. But for most situations, we do see our receptors becoming more sensitive. We also see some changes in the physiological reserves, and this causes sensitivity to adverse effects of the medications. For the brain, we do see decreases in the neurotransmitters. That does make our brain more sensitive to adverse CNS effects as we age. In the eye, we do have vision changes that commonly occur. Many medications can cause some blurred vision, and we are going to be more sensitive to that blurred vision if we already are having some vision changes. Cardiovascular-wise, there's many changes occur, but the one that really does affect medications quite a bit is the loss of sensitivity of our baroreceptors to respond when our blood pressure changes. So we may not respond to a low blood pressure as quickly as we would when we were younger, and that leads to adverse medication events. We've already talked about what happens in the liver and in the kidney. So let's review. Why are older patients more sensitive to the adverse effects of medications? Is it due to changes in the absorption, distribution, metabolism, and excretion of medications that occur as patients age? Is it due to the fact that drug receptors become more sensitive to medications as aging occurs? Is it because as aging occurs, changes occur in organ function that make older patients more vulnerable to side effects? Or is it all of the above? So very good for those of you who have been listening and did get the correct answer of all of the above. So back to Mr. and Mrs. Harrison. Mrs. Harrison states she felt much better once it was determined that one of her medications was causing some of her problems, and that got stopped. She also let you know that after stopping this medication, she was able to stop 2 more of her medications. So how does this happen? And is it common? When we have an unrecognized adverse drug reaction that leads to the addition of another medication to treat that adverse reaction, we call that the prescription cascade. And yes, it is fairly common in our older patients. I have an example here of a medication called metoclopramide, which is often used for gastroparesis. It is cleared by the kidney, so the dose generally does need to be adjusted in our older patients. In this particular patient, we did not adjust the dose, and we ended up with the patient having a side effect from the medication, which was Parkinson's type symptoms. We added a medication to treat Parkinson's disease, but that particular medication did not have enough carbidopa in that dosage form to actually block the side effects of the levodopa. So carbidopa is in that combination product to block those side effects, and we ended up getting that patient having some severe nausea associated with the carbidopa levodopa, and we ended up adding the promethazine to help to treat that nausea. Promethazine is an anticholinergic medication. It blocks cholinergic receptors, and we did talk about the fact that we have less cholinergic function or less cholinergic neurotransmitters in our brain. So our older patients are particularly sensitive to the side effects of anticholinergic medications such as promethazine, and that patient did actually get some confusion and was actually started on a medication to treat dementia, donepezil. So getting rid of that one medication, metoclopramide, coming up with something different to use for that or using a lower dose potentially would have gotten rid of all these other medications as well. So the most important thing that we can do to prevent the prescription cascade. So rather than tell you, I thought I might ask you, what is the best way to avoid the prescription cascade? Is it to use only non-pharmacological methods to treat older patients? Is it to choose only medications that have been well studied in older patients? Or is it to treat each new symptom as an adverse effect of a medication until proven otherwise? Those of you who picked choice 3, that is the correct one. Choices 1 and 2, although we would like to be able to do that, it just is not always possible. So if you take one thing away from this presentation, I would like you to remember to treat each new symptom as an adverse effect until proven otherwise. So look for the medication that's causing the side effect before adding another medication. If you do that, we'll avoid the prescription cascade. Thank you for your attention.